Hello, I'm Peter Voore. I'm the Medical Director of the Ambulatory Care and Structured Treatments Program, which includes the addiction services, the mood services, the women's services, and trauma-related services. I think there are many barriers that do prevent psychiatrists from treating addictive disorders, and I think some of the most challenging ones have to do with our own internal conception of what a psychiatrist is. I think that either through our training or through our experience, there is still a struggle within psychiatry to accept that addictions are part of the work that we have to do. Addictions are included in all the DSMs, but for some reason, I think we gloss over those pages. We don't take them seriously, and most importantly, I'm not sure that we fully have accepted that this is part of our professional identity, and that when we see patients, really understanding the addictions that they face and exploring those in detail is absolutely as important as looking at their mood symptoms, their symptoms of psychosis, their symptoms of personality disorder, and all other areas of functioning. Because in so many ways, it's the addictions that will really counter all our attempts to treat those other symptoms or categories of symptoms and diagnoses. So we need to see the patients much more holistically and include the addictions in our treatment planning and most importantly in our thinking about our patients. During my psychiatric training as a resident, in retrospect, I had almost no teaching in addictions whatsoever. I think what I've learned about addictions has really been through my patients and through what I've discovered I didn't know about addictions and what I had to explore myself and speak to addictions colleagues about and to try to learn about this. I realized about 5 years ago that too many of my patients were drinking too much. So I had to teach myself how to use naltrexone and acamprosate. I asked questions about some of my colleagues and discovered how easy these medications are to use and how effective they are. I had to do that myself. So let me tell you a little bit about my experience with treating patients with concurrent disorders, because I've been in the psychiatry business for over 25 years. At the beginning of my career, I worked at the Clark Institute with ARF out the back door. And so I was expert in rerouting patients who had an addiction to say, no, you have to go to ARF first before I'll treat your mental disorder. And in fact, I trained many staff to do that. So I was part of the problem at the beginning. But increasingly over time, I realized that for me to effectively treat patients with psychiatric disorders, I couldn't ignore the addictions. I can give you a few recent examples of a young artist that I'd been treating with a bipolar disorder for some years. And he came back to see me and had previously been treated with naltrexone, and his mood was again problematic. He had continued his lithium treatment quite religiously, but it was really the addiction piece and the alcohol which were the main problems at this point, which were really not enabling him to stabilize his mood and to function better. So it wasn't the lithium I needed to talk about, it was the naltrexone that he had previously been on. And I knew that unless we dealt with the alcohol issue, I wouldn't be able to get him to function better. So I had to really take on my responsibility as a psychiatrist to see the whole picture and include the addictions. And I saw him a few weeks later, and with the naltrexone, he had halved the amount of alcohol that he was drinking. Very quickly, it was very effective, and he commented about how useful that had been. Let me tell you about a patient whom I saw recently in the mood disorders consultation service. This was a patient with a bipolar disorder for some years, and he was coming with a request from the family doctor to help him with further mood stabilization and functioning. He still had depressive symptoms, and he had difficulty in his relationship with his wife. I certainly looked at his history of pharmacology and mood symptoms and clarified the bipolar diagnosis, which was not in question. But there was an issue of how much he was drinking. This man was drinking 30 drinks a week. and had seen many psychiatrists in the past who'd counseled him about his mood medications and really had not addressed the alcohol issue. So I made a simple intervention of talking about safe drinking and the consequences of that amount of alcohol on bipolar disorder, and I said I would work with him to follow up to see if he could do something about his alcohol intake. He was intrigued because psychiatrists hadn't spoken to him about the alcohol before. And so even in 3 weeks follow-up later, he had significantly decreased his alcohol intake and his mood had improved. I feel that if I would have said, you have a problem with alcohol, go to another clinic, or someone else should take care of that, I would have lost an opportunity of using the therapeutic alliance I already had with this person to follow through and do the alcohol work myself with the patient, knowing that I can fiddle with the medications, but it was the alcohol that was really stopping his mood from further stabilization. Let me talk about some of the reasons why I think we missed the boat here. And as much as we as psychiatrists are unsure whether addictions should or should not be part of psychiatry, I think patients come with the same dilemma. They can identify their depression, sometimes their psychotic symptoms and their anxiety, and they too don't want to talk about their addiction. And they too forget, or because of stigma, don't really want to talk about how much the alcohol, the cocaine, the party drugs actually have affected their lives and changed how they function as people. I think the stigma probably works both ways. For psychiatrists, for some reason, we still struggle with it. Patients have the same struggle. So there in the treatment room, we both don't want to talk about it. So we really need to keep it top of mind and deal with our own countertransference and help the patient with their feelings of shame, of stigma, and actually not even realizing how much an addiction has affected their lives and interfered with their treatment for a mental illness. I mean, look at the example bipolar disorder. It is so clear half of the patients with bipolar disorders struggle with an addiction. We don't spend enough time talking about that. And so patients repeatedly get readmitted and they have major troubles in functioning in their lives because maybe we can make comments about their medications, but without dealing with the addiction piece, we really haven't finished our work. In psychiatry, we have many problems with patients who relapse because they stop medications. And routinely in the emergency department, patients will return because their psychotic symptoms or depressive symptoms have recurred because of medication noncompliance. And in psychiatry, we accept this as part of a normal process that these things happen in psychiatry. We have to keep on working on patient motivation, on psychoeducation about their illness, and to help patients accept their illness and move forward. So why don't we do the same thing with addictions? Why is it when someone comes back and they've been abusing a substance, somehow it's not the illness anymore? It's the patient who's done something wrong and abused a substance. So I think we need to apply the same thinking to addictions as to other mental disorders. The other thing, think of the area of cancer. Would we ever blame a cancer patient for a recurrence of their cancer? It's unthinkable. So why do we keep doing this in addictions, that there's somehow something wrong with the person if they keep abusing their substance? This is part of the illness, and that's what we need to work with our residents on, in helping them understand and accept this is part of the treatment that we have to do.